Welcome to the Funnel Effect. Today, we are opening up a significant review article published just today, January 22, 2026, in the New England Journal of Medicine.
Mm.
The title of the paper is Cardiac Physiologic Pacing, and it's authored by Dr. Mihail G. Chalou, Dr. Jeannie Poole, and Dr. Kenneth A. Ellenbogen.
It is good to be here. This is a substantial piece of work. When you see a review of this magnitude in the NEJM, especially one dealing with the very mechanics of the heart, it usually signals that the ground is shifting beneath our feet.
Right. It's not just an update. It's a reevaluation.
It's a reevaluation. We're talking about a fundamental update to how we treat a huge number of patients with heart failure.
Absolutely. And to establish the stakes right up front for you listening, this isn't some niche issue. The source material highlights that between 80,000 and 120,000 patients get these cardiac resynchronization therapy, or CRT, devices every single year.
And that's just in the U.S.?
Just in the U.S. That is a stadium full of people annually getting hardware implanted to help their hearts beat better.
Right. And for 20 years, it's been a standard of care. But the mission, I think, of this deep dive is to explore a transition that's happening right now. We're moving from the era of cardiac resynchronization therapy.
Which sounds very mechanical.
It is mechanical. And we're moving to a broader, more, biologically accurate concept called cardiac physiologic pacing.
That shift in language is really interesting. Resynchronization sounds like a brute force fix, whereas physiologic sounds like we're trying to work with the body.
That is exactly the distinction. I mean, think about it this way. For the last 20 years, we've been treating electrical failures in the heart by bypassing the grid. We just hot-wired the heart.
Okay.
Now we are learning how to repair the grid itself. The heart is a mechanical pump, yes, but that pump is a slave to its electrical system. And if the electricity is bad, the pump fails. It's that simple.
So let's start there. Let's start with the problem before we get to the new solutions. The paper spends a good amount of time explaining desynchrony. In a perfectly healthy heart, how is this all supposed to work?
So in a healthy heart, you have this incredible specialized conduction system. You can think of it like a high-speed fiber optic network.
Okay.
The signal starts at the top, travels down to a little junction box called the AV node, and then it hits the express lanes, the His bundle, and the bundle branches.
The superhighways.
Superhighways. And it ensures that the ventricles, the main pumping chambers, squeeze in perfect harmony at the exact same millisecond.
I always like the analogy of a rowing crew. You've got 8 rowers, 4 on the left, 4 on the right.
That's a perfect visualization. In a healthy heart, the coxswain yells row, and every single oar hits the water at the exact same time. The boat just glides. It's efficient.
Smooth.
Very smooth. But in heart failure, specifically when you have a condition called a left bundle branch block, that fiber optic line on the left side is cut. It's broken.
So the signal can't take the highway anymore.
It can't. It has to take the scenic route, crawling cell by cell through the actual muscle tissue.
Which is much, much slower.
Oh, incredibly slow in electrical terms. So the right side of the heart gets the signal instantly and contracts.
It pulls.
It pulls. Meanwhile, the left side is still waiting for this slow-moving signal to crawl over to it. By the time the left side finally squeezes, the right side is already starting to relax.
So back to the boat. The right side rowers pull hard, and the boat just veers to the left. Then a second later, the left side rowers pull, and it veers back to the right.
Exactly. The boat just wobbles. It expends a huge amount of energy, but doesn't move forward very efficiently. In the heart, we call this desynchrony. The walls wobble instead of squeezing together.
And the consequence of that wobble?
It's devastating for the pump function. This wobble dramatically reduces the left ventricular ejection fraction. That's the percentage of blood pumped out with each beat. The heart is working harder and harder to do less and less work.
And for 2 decades, the fix for this wobble has been biventricular pacing, or BV. This is what the authors here call the old standard. How did we tackle this problem initially?
Well, the logic was pretty straightforward. The internal wiring is broken, so let's ignore it.
Okay, let's run new wires.
Let's run new wires on the outside. We decided to place leads, these are the wires, in specific spots to force the heart to beat from 2 different places at once. You put one lead in the right ventricle. That's pretty standard.
Mm-hmm.
But to fix the timing issue, you have to get a signal to the left ventricle at the same time.
But as I understand it, you can't just shove a wire inside the left ventricle, right?
No, absolutely not. That would be a catastrophe. The left ventricle is a high-pressure chamber pumping oxygenated blood to your brain, to your whole body. If you put a foreign object like a wire in there, You will form clots, and you will cause a massive stroke.
So doctors had to find a loophole, a back door,
A back door, exactly. And they found it in the coronary sinus.
which is a vein.
It's a big vein that conveniently wraps around the outside of the heart. So surgeons learned to thread a very skinny lead through this vein and park it on the epicardium, the outer surface of the left ventricle.
So you have a wire inside the right chamber and another wire sitting in a vein on the outside of the left chamber, and you just fire them both at the same time.
That's the bi in biventricular. You stimulate both sides simultaneously. You're creating what's called a fusion beat. You're essentially shouting at the rowers from both sides of the boat at the exact same time to force them back into some kind of rhythm.
It sounds a bit like a brute force method, I have to say.
It is a brute force method, but for a long time it was the only method we had, and we can't argue with the results. The article lists what I would call the Hall of Fame of clinical trials supporting this.
Yeah, the evidence is pretty overwhelming.
Oh, the evidence is massive. We're talking about well over 10,000 patients in major randomized trials. The review specifically highlights Companion and CARE-HF. These were the studies in the mid-2000s that really, truly changed the game.
Let's look at Companion. That was over 1,500 patients, a huge study.
A huge study. They took patients with advanced heart failure, class 3 or 4, people who are short of breath just walking across a room, and they gave them BIVI pacing. The results were clear. It significantly reduced the combined risk of death or hospitalization compared to just giving them medication.
So it wasn't just a quality of life improvement, it was a survival benefit.
A real survival benefit. And then CARE-HF came along and confirmed that, even showing a reduction in sudden cardiac death. So BIVI became the gold standard. If you had heart failure and this wide electrical signal on your ECG, you got this device.
But the review brings up a very important nuance, this Goldilocks zone about who actually benefits. It's not for everyone.
No, and this is a crucial point that determines who gets a device. It's all about the QRS duration. That's the width of that big spike on the ECG.
Okay.
The wider the QRS, the more desynchronous the heart is, the more wobbly the boat is. The data is crystal clear that the greatest benefits of BIVI are concentrated in patients with a QRS of at least 150 milliseconds and a left bundle branch block pattern.
So what happens if the QRS is narrower? Let's say someone has heart failure, but their QRS is under 130 milliseconds.
The benefit vanishes. In fact, the source mentions the ECHO-CRT and Rethink-Q trials, they were sobering. They showed that trying to resynchronize a heart that isn't that wide electrically doesn't help.
It could even make things worse.
It might even cause harm. I mean, if the rowers are already mostly in sync and you start shouting and shocking them from the outside, you're just disrupting the natural flow.
So BV is great for the right patient, but the whole premise of this article is that we're moving away from it. So if it's so good, why are we looking for something else?
Because it doesn't work for everyone. This is the big, frustrating problem of the non-responder.
And the non-responder rate.
Even with perfect patient selection, the right QRS width, everything, about 1/3 of patients, 30% or more, simply don't get better with biventricular pacing.
1 in 3. That's a remarkably high failure rate for a therapy we call a gold standard.
It's frustratingly high. And the reasons are often just down to messy anatomy. Remember, for BV to work, you have to successfully navigate that lead into that little coronary sinus vein on the outside of the heart.
And biology isn't always neat.
Biology is never neat. Sometimes that vein just isn't there, or it's too small, or it's in the wrong spot, far away from where you need to pace. You might be pacing the heart, but you're pacing it from a suboptimal angle. You aren't really fixing the physiology. You're just managing the chaos.
Which brings us to the core of this deep dive. The paradigm shift. We are moving to conduction system pacing, or CSP.
This is the really exciting part. The concept is so elegant and simple. Instead of bypassing the broken wire, what if we just jumped the gap?
Okay.
What if we paced the specialized tissue itself, the his bundle or the left bundle branch, to restore the heart's natural activation sequence from the inside?
The source breaks this down into 2 main contenders. Let's start with option A, his bundle pacing.
The bundle of his. Conceptually, this is the holy grail of pacing. It's the main trunk of the electrical tree, right after that AV node junction box. If you can successfully pace here, you're utilizing the entire natural conduction system.
Both ventricles activate exactly as nature intended.
Exactly. It's the most physiologic solution possible.
When I read the anatomical description in the paper, it sounds incredibly difficult, almost impossible.
It is microscopic. The average length of the his bundle is 2.6 millimeters. Its width is about 3.7 millimeters. And it's not just sitting there. It's encased in a tough, fibrous body deep inside the wall of the heart.
So the doctor has to guide a screw-in lead inside a beating heart and hit a target that is roughly the size of a single grain of rice.
That's the challenge. It requires immense skill, patience, and a little bit of luck. But the payoff, when you get it, is visible immediately on the ECG. The paper includes figure 2, which is just, it's striking.
Talk us through it.
It describes a patient with a baseline QRS of 190 milliseconds. That's extremely wide and messy. Their heart's pump function, their ejection fraction, was down to 35–40%.
So a very sick heart.
A very sick heart. And then they hook up his bundle pacer.
And what happens?
The QRS just snaps down to 82 milliseconds. It becomes a sharp, narrow, beautiful signal. It looks like a healthy heart's ECG. And crucially, the ejection fraction recovered to 60–65%.
That's a normal heart.
That is essentially a normal squeeze. It's a complete electrical and mechanical recovery.
So if it works that well, if it's the holy grail, why isn't everyone getting his bundle pacing? What are the deal breakers?
Well, hitting that target is one thing, but maintaining it is another. The source notes that his bundle leads have high thresholds. Because that bundle is wrapped in that fibrous, almost scar-like tissue, you have to use more electricity, more battery power to stimulate it.
And a dead battery means another surgery.
Exactly. It drains the battery much faster. Plus, the lid revision rate is unacceptably high. The lead can slip just a millimeter, or the threshold can creep up so high that the device simply can't capture the heartbeat anymore. So it's physiologically perfect, but technically it's just very, very finicky.
Which opens the door for option B. The text calls this the dominant player in this new era. Left bundle branch pacing, or LBBP.
This is where the whole field is rapidly consolidating. If his bundle is the tiny trunk of the tree, the left bundle branch is the thick, sprawling limb that branches off right after it.
Why is this target so much better?
It's strictly a matter of real estate. The left bundle is wide and diffuse, it spreads out like a fan, and it can be up to 14 millimeters in width. So instead of aiming for a single grain of rice, you're now aiming for a much larger landing strip.
That makes sense. But the technique described here sounds aggressive. You're screwing the lead deep into the interventricular septum.
Yes. You are literally burrowing the lead into that thick muscular wall that separates the right and left ventricles. The goal is to screw it in just deep enough to catch the left bundle branch, which lives on the other side of that wall.
And what are the advantages of this over the more delicate, his bundle pacing?
Stability. Once that screw is deep in the muscle, it tends to stay there. The thresholds, the amount of energy you need, are low and stable.
Better battery life.
Much better battery life, and the success rate is just dramatically higher. The Milo study, which is cited in this review, showed a procedural success rate of 92.4% for left bundle branch pacing.
92% is very impressive. But I have to come back to this idea of drilling through the heart wall. Is there a risk of going too far?
There is. You can perforate the septum and actually punch the lead right through into the left ventricle. The Milo study noted this happened in about 3.7% of cases.
That sounds terrifying, poking a hole into the high-pressure chamber of the heart.
It sounds much worse than it usually is. The article reassures us that it's actually easily recognized during the procedure. The operators see it happen in real time on the monitors.
What would they do?
You just withdraw the lead a few millimeters, and the muscle seals itself off pretty much instantly. It rarely causes any long-term issues, but it does highlight that this is a procedure requiring a new set of skills. You can't just be close enough.
So we have the old guard biventricular pacing, which has 20 years of solid mortality data, but this high non-responder rate.
Right.
And we have the upstart's conduction system pacing, which make so much more physiological sense but are newer. How do they actually compare head-to-head in the data?
This is the data showdown section, and we have to be really rigorous and intellectually honest here. We have massive level 1 evidence randomized controlled trials, or RCTs, for BBV.
The gold standard of evidence.
The absolute gold standard. For conduction system pacing, what we have right now are mostly observational studies and a handful of small randomized trials.
Okay, so let's talk about those small trials first. The source lists his SYNC and his alternative.
Right, these were the early signals. They were small, but they were important. They showed that his bundle pacing could narrow the QRS and improve that ejection fraction just as well as, or in some cases even better than, traditional BV. But again, the sample sizes were tiny dozens of patients, not thousands.
And then there was the LBBP-RSANC trial for the left bundle technique.
Right, only 40 patients. Teeny tiny. But it showed that left bundle pacing actually led to a greater improvement in the ejection fraction than BV did. The pump got stronger.
But what about how patients felt?
That's the interesting part. When they looked at the clinical outcomes, like how far the patient could walk in 6 minutes, the results were similar.
So a better number, but not necessarily a better feeling patient, at least in that small group.
Exactly, which is why we need bigger trials.
Now, the heavyweight in the room for this new technology seems to be the ICLAS study. The paper spends some time on this. It wasn't a randomized trial, but it was a massive look back at the data.
The International Collaborative LBBP study, yes, this is a very important piece of the puzzle right now. They looked back at the records of nearly 1,800 patients from centers all over the world. And the findings were, well, they were pretty striking.
What did they find?
Patients who got left bundle branch pacing had a significantly lower incidence of death and heart failure hospitalization compared to those who got traditional BV pacing.
Wow.
And not only that, they also had less new onset atrial fibrillation and fewer dangerous ventricular arrhythmias.
That sounds definitive. Lower death, fewer hospitalizations, fewer arrhythmias. Why isn't the debate over right now?
Because it's retrospective. This
Yeah.
is the classic scientific trap, and we have to be so careful. We are looking back at decisions that doctors already made. There could be selection bias,
Meaning what?
meaning maybe the doctors instinctively chose the younger, healthier patients for the new, cool procedure, and maybe the sicker, more complex patients got the old standard BV. We can try to adjust for that with statistics, but we can't ever know for sure.
I see.
And that is why the source repeatedly and correctly emphasizes that we are all waiting for the results of the ongoing large randomized trials, like PROTECT-HF and left versus left. Those will give us the definitive answer.
So until Protect-HF publishes, we're in this interesting transition period. But there's another group of patients mentioned in the text that I found fascinating. These are people who don't have heart failure yet.
Ah, yes, the AV block patients.
Right. Their heart pump is strong, their squeeze is normal, but the electrical signal from the top to the bottom is blocked. So they just need a pacemaker to keep their heart rate from getting too slow.
And traditionally, for decades, we just put a single lead in the right ventricle and pace them 100% of the time. Simple fix.
But the article suggests that was actually a bad idea.
A very bad idea, it turns out. We call it pacing-induced cardiomyopathy. The BLOCK-HF trial proved it. It showed that if you take a healthy synchronous heart and pace it only from the right ventricle all the time, you can actually cause heart failure over the years.
You're creating the wobble. You're giving them the very problem you're trying to fix in other patients.
You are creating the wobble, exactly. So the new guidelines and this review are strongly suggesting that for these patients, conduction system pacing, either his or left bundle, should probably replace standard right ventricular pacing. If you need to pace the heart, pace it the way nature intended. Don't create a problem you'll have to fix with a more complex device later on.
That just seems so logical. Now, I want to dive into some of the technical nuances the authors described because this stuff is fascinating. There's a section on defining success. It seems it's not as simple as just screwing the lead in and seeing what happens.
No, not at all. You have to be a real detective with the ECG. The paper references Figure 3, which shows a patient with LBBB a wide QRS of 138 milliseconds. They do the procedure, and the QRS tightens beautifully to 86 milliseconds. But the expert commentary notes this really important distinction between true left bundle branch pacing and something called left ventricular septal pacing.
What's the difference between those two?
It's a game of millimeters. In true capture, your screw makes direct contact with the conduction system wire. You've hit the highway. In septal pacing, you've missed the highway, but you're pacing the local muscle right next to it.
And does that difference matter?
The emerging data suggests that true capture is superior. You get the best electrical and mechanical result. But what's really interesting is that septal pacing, just hitting the muscle nearby, seems to perform about as well as traditional biventricular pacing.
So even if you miss the bullseye and just hit the board, you might still be doing as well as or better than the old standard.
That seems to be the case. It gives the operator a little bit more margin for error, which is a good thing.
Now here's where it got really interesting for me. The hybrid approaches. The article mentions these acronyms, HOT-TCRT and LOT-TCRT, and almost a why not both approach.
Is exactly a why not both approach. This is for the most complex, difficult to treat hearts. HOT-TCRT is his optimized CRT. LOT-TCRT is left bundle optimized CRT.
So how do they work?
You put in a conduction system, let's say, into the left bundle to get that fast internal activation. But you also put in the old school coronary sinus lid on the outside of the heart.
You use both leads. Why would you do that?
It's a belt and suspenders strategy. Maybe the conduction system lead corrects 90% of the electrical delay, but the heart is so big or so scarred from a previous heart attack that you still need that extra little push from the outside to get a perfect coordinated squeeze. The device then uses sophisticated algorithms to time them to fire together perfectly.
It's a highly customized, patient-specific strategy.
The ultimate in-personalized medicine for pacing.
There's also an economic angle to all of this. Medical technology is usually astronomically expensive. Does this new, more physiologic tech cost more?
Surprisingly, it might actually cost less in the long run. Think about the hardware. For traditional BV, you need a specialized, very expensive CRT generator, the battery pack,
Yeah.
and you need that complex, specialized coronary sinus lead. For conduction system pacing, you can often use a standard, less expensive pacemaker generator and standard off-the-shelf leads. You're just placing them more cleverly. And in many cases, you only need one lead to resynchronize the heart instead of two.
Do you save on hardware costs?
You save on hardware. Plus, if the battery lasts longer because of the lower, more stable thresholds.
It's fewer replacement surgeries over the patient's lifetime.
Exactly. Fewer surgeries, fewer risks, lower costs to the system. However, there is one little note of caution in the text about lead extraction.
Right. If a system gets infected, you have to pull the wires out.
You do. And the source notes that so far, extraction success for these new leads is very high, 100% in one study they cite. But these are new leads. We still need to see how hard they are to remove after they've been scarred into that deep muscle for 10 or 15 years. The jury's still out on that.
So bringing this all back to the patient in the room. If I'm sitting in a doctor's office in 2026 listening to my options, the conversation has changed completely.
Oh, drastically. A few years ago, the conversation was simply, you have heart failure, you have a wide QRS, you need a biventricular pacemaker. End of story. Now, it's a much more nuanced discussion about your specific anatomy and your options.
Let's just summarize this evolution for everyone listening. We started with right ventricular pacing, easy to do, but we learned it could be harmful. We moved to biventricular pacing, proven to save lives, but complex, and it doesn't work for 1 out of every 3 people.
Right.
And now we have conduction system pacing, which is more physiologic, technically precise, and looks incredibly promising.
But, and this is the critical takeaway for today, BV is still the official gold standard in the guidelines.
Because of that massive body of randomized trial evidence.
Because of that evidence, CSP is the challenger. It's the heir apparent with superior physiology and really promising observational data. The tipping point, the moment the crown is passed, will be when we see the results of those ongoing large trials like PROTECT-HF.
That leads me to a final provocative thought. We've spent this time dissecting the data, the wires, the techniques. But what does this really mean for the future of how we think about this?
I think if conduction system pacing proves superior in these big trials, as many of us suspect it will, we might look back at 20 years of biventricular pacing as a bridge technology.
A bridge technology. What do you mean by that?
I mean, like the DVD player before streaming video became ubiquitous. It was a clumsy but absolutely necessary and life-saving step. We were treating a fundamental electrical problem with a mechanical bypass. We were shouting at the heart from the outside because we didn't know how to whisper to it from the inside.
Wow.
Now that we're finally learning how to tap into the heart's own wiring, we're finally treating the root cause of the dyssynchrony. We're not just managing the chaos anymore, we're restoring the order.
That is a powerful image. And it means that if you or a loved one needs one of these devices, the vocabulary has changed. Asking your doctor about physiologic pacing or left bundle pacing is now a very valid, very educated question to bring into that conversation. Thank you for watching The Funnel Effect.